Good morning. I'd like to thank the Aspire organizers, especially the Embryology SIG, which has given this topic, and I'm very happy to deliver the topic on the impact of COVID-19 on the reproductive system, which is a very academic topic, but nonetheless extremely important for our field. These are my disclosures. To date, we've been within the pandemic for about 10, 11 months. And the count as of November 15, 2020 was about 53 million cases of COVID all over the world. In Asia, the count is short of 15 million. Because of the pandemic, very early on, there were international bodies that gave guidelines on how fertility care should be implemented. These include the suspension of new treatment cycles, the cancellation of embryo transfers, the suspension of elective surgeries, and to minimize in-person contact. Along the way, when people may have learned a little bit about the virus, there were adjustments in the guidance, and these included the restarting of ART cycles, but to prioritize time-sensitive conditions such as fertility preservation and advanced maternal age, but still to minimize in-person contact and encourage telemedicine. More recently, however, with the pandemic still going strong, there were recent guidelines by such groups as IMPMART, which now encourages to provide reproductive counseling and ensure safe delivery of reproductive technology despite the pandemic. In Asia, the first regional guideline or position statement about ART will soon be released by Aspire after they conducted a survey regarding practices during the pandemic, and they would be giving recommendations. I will not be discussing those, but just to let you know that these guidelines will soon be coming out as published in the Fertility and Reproduction Journal. And yet, there are these new studies coming out that delayed fertility treatment has a negative effect on mental health of patients during the pandemic. In a study of 92 respondents, they reported an 86% negative impact on their mental health, and over 50% had depressive symptoms with a significant decline in mental health and overall quality of life. So these has to also to be incorporated and balanced with the need to delay fertility treatment. The role of giving recommendations is to keep patients and healthcare workers safe from contracting COVID-19, prevent COVID-19 from contaminating the fertility treatment process, and to avoid future pregnancies from possible harm during COVID-19 infections. So our knowledge about the impact of COVID-19 on health and reproductive system is important in advising the future course of action. So these are the issues that we need to review. How is SARS-CoV-2 transmitted? Is there sexual transmission of COVID-19? And is male or female infertility affected by SARS-CoV-2? First, we talk about the transmission of the virus. As you well know by now, the coronavirus with its spike protein will be entering our cell after the activation of its S protein by the transmembrane protease serine 2 or your TMPRSS2. Once activated or primed, it will couple with the ACE2 or your angiotensin converting enzyme 2 receptor to attach to the cell. So these two basic interactions hallmark the entry of the cell into the entry of the virus into the cell. So both ACE2 and TMPRSS must be expressed to allow cell entry. And once inside the cell, The complex process of replication will begin until replication is completed and new viral elements are released outside the cell by exocytosis. What is the significance of knowing the location of ACE2 receptors? There are two major reasons. We already know that the ACE2 receptor is the point of entry for the SARS-CoV-2 virus. However, even before SARS-CoV-2 came into the picture, the ACE2 receptors were already local receptors for various other functions in the human body. And the most significant of this is your renin angiotensin aldosterone system. With ACE2, there it converts angiotensin 2 to angiotensin 1 to 7 so that the actions of angiotensin 2, which were vasoconstriction, inflammation, fibrosis, and proliferation, would now be converted to vasodilation, vasoprotection of hypotension after the angiotensin 2 is converted to angiotensin 1 to 7. And this protective mechanism is the one that works for the kidneys, the cardiovascular system, for diabetes, and for your CNS and reproductive system. So the presence of SARS-CoV-2 disrupts this protective effect of your ACE2 meant for other functions. Once again, in the presence of ACE2, your angiotensin 2 will be converted to angiotensin 1 to 7 so that the protective effects of your vasodilation, anti-proliferation, anti-inflammatory, antifibrotic, and antithrombotic effects will be there. Diagrammatically, with the SARS-CoV virus, it locks into your cells, into your receptors, preventing the conversion of your angiotensin 2 to angiotensin 1 to 7, causing lung injury, adverse myocardial remodeling, vasoconstriction, and vascular permeability. And this paper by Chang explains it all, that there is COVID-19 damage outside the respiratory system, affecting the digestive system, the urogenital system, and the central nervous system and the circulatory system because of these systemic effects. But outside those, let's examine if there will be local effects in the various organs where ACE2 receptors are found. And they are found all over the human body, including the reproductive system. We already know that the respiratory system is the main target of SARS-CoV-2. However, they can be found in the digestive system, sensory and nervous system, the lymphatic system, the cardiovascular system, and our point, the reproductive system. And in the reproductive system, they've shown that ACE2 receptors are found in the placenta, the decidua, the testis, the prostate, and even in first trimester placenta. Let's now proceed to our second issue, which is the possibility of sexual transmission of SARS-CoV-2. The reason why we must answer this is because it will enable us to make appropriate guidelines involving fertility procedures such as spontaneous pregnancy, timed intercourse with or without ovulation induction, IUI, IVF in its variants, and gamete and fertility preservation, gamete freezing, that is, and fertility preservation. So to answer this, we must review the studies on the presence of SARS-CoV-2 in the semen and in vaginal fluid. In the semen, Pan studied 34 men and tried to confirm the presence of SARS-CoV-2 in these men who were confirmed COVID-19. In his study of these 34 men, there was no SARS-CoV-2 found by RT-PCR in the semen. And he also found there was sparse expression of ACE2 and TMP RSS2 with almost no overlapping of the gene expressions. So he concluded it was unlikely that SARS-CoV-2 will occur within the human testicle. A second study or a different study by Song found the same findings. He studied 13 men that were confirmed by having COVID-19 by PCR, of which 11 were mild COVID, one asymptomatic COVID, and one already a deceased patient with COVID. And he tested their semen or the biopsies with RT-PCR, and they confirmed SARS-CoV-2. They did not find SARS-CoV-2 in the semen and testicular biopsies of these patients. Then comes the study by Lee et al. And this was a study on 50 patients where they were able to get samples from 38. And this is what they found. They found six that were positive for SARS-CoV-2 by RT-PCR in the semen. Four of them were in the acute stage, and two were in the recovered stage. And they did not find any difference in the clinical characteristics between patients that were positive and that were negative. They concluded that the male reproductive tract may be potentially infected by COVID-19 and that the virus is probably unable to replicate in the testes because of the sparse ACE2 and TMPRSS2 receptors. And this is probably because they're just persisting in the semen. This study by Massarotti tries to explain it. Where does the SARS-CoV-2 in the semen come from? He says that there is confirmed presence of receptors in the testis, but it is not a proof of viral infection and replication. And there is no proof that SARS-CoV-2 can pass the blood testis barrier. So the RNA detected in the semen could just have been a residual of urinary shedding. In the same paper, he also did find, however, that there seemed to be dual presence of ACE2 and TMPRSS2 in various stages of spermatogenesis and also in the male accessory glands. So this bolstered the thought that probably SARS-CoV-2 can potentially infect the male genital tract. Let's now talk about the presence of SARS-CoV-2 in vaginal fluid. And there are three available studies trying to confirm this. One by Q, studying 10 patients, Asian, studying 12 patients, and Kui, studying 35 patients. And in all three studies, vaginal swabs revealed negative for SARS-CoV-2. However, in the quiz study, there were also cervical cells that were tested and that was negative. And there was an anal swab done, and one patient was positive for COVID-19. But let us review the various other studies that tried to find the presence of SARS-CoV-2 in body fluids. We already know that SARS-CoV-2 can be easily isolated from nasal swabs or oropharyngeal swabs, the saliva, and even from stool or anal swabs. But what not too many know is that they can be isolated from tears, from urine, from breast milk, and from semen. In this paper by the International Planned Parenthood Federation, they recognized that COVID-19 is a serious disease, but they reviewed that there was a small number of cases where the virus was found in the semen of men and in vaginal secretions of women with COVID-19. And yet, there was no evidence that the virus can be sexually transmitted. However, they argued that sex is not only coitus, it includes intimate touching, kissing, and those increase the risk of transmission. So, for the question, is there sexual transmission with SARS-CoV-2? There is no evidence of the virus in the vaginal fluids, but there are unconfirmed evidence that SARS-CoV-2 may be found in semen. So we need more studies. However, sexual transmission is not necessarily only through coitus. It includes intimate touching, kissing, even intercourse, and others. So the sexual act may result in viral transmission considering all other routes where SARS-CoV-2 has been isolated. Let's go to our final question. Does SARS-CoV-2 affect fertility? To do this, let us separately discuss its effect in male fertility and female fertility before studying both. We already showed this paper by Maserotti where there seemed to be a preponderance of dual presence of ACE2 and TMPRSS2 in various stages of spermatogenesis and in various glands in the male accessory glands. This study by Wang and Su further explains the risk. This is a study on the presence of gene expression in the spermatogonia and in Leydig and Sertoli cells. The red being those processes associated with viral reproduction and transmission, and those blue representing processes associated with male gamete generation. So those connected with viral reproduction are increased, and those related with male gamete generation are decreased in patients with SARS-CoV-2. So these findings are very ominous for the possible negative effect of SARS-CoV-2 in the male reproductive tract. And in a separate paper by Dutta, he tried to explain the possible multifaceted pathology of SARS-CoV-2 in male infertility. He said that men are reportedly more vulnerable with a higher fatality rate compared to women. And ACE2 receptors are profoundly expressed in testicular cells, and hypogonadism has been reported in acute phases of some COVID-19 cases. And also, uncontrolled inflammatory responses may lead to systemic oxidative stress, disrupting testicular functions. So, because of this, he postulated several mechanisms how SARS-CoV-2 infection can target the male. So when the cell is already entered by the virus, it can attack the epididymis to the testis and cause orchitis and result in oxidative stress with disrupted spermatogenesis. Same pathway when they affect the Leydig cells, causing decreased testosterone, affecting your Sertoli cells, again, disrupting spermatogenesis and resulting in sperm abnormalities. An infected man will have psychological stress, and they may be receiving antiviral drugs, both of which can cause oxidative stress that can affect DNA, increased DNA fragmentation in the sperm, and also disrupted spermatogenesis with sperm abnormalities. He concluded that the testis could be a potential target for COVID-19 infection and that SARS-CoV-2 may directly invade the tissues through ACE2 receptors and cause inflammation and immune responses and result in testicular damage and dysfunction to cause a decline in male fertility. There are other reviews regarding the same topic where there is an adverse effect of SARS-CoV-2 infection on male fertility. Let's now talk about the effect on female fertility. ACE2 is expressed well in the human ovary based on these studies by rays using electrophoresis and autoradiographic localization. Similarly, there are expressions of SARS-CoV-2 genes in the endometrium as discovered by Henarejos Castillo. They found low expressions of ACE2 and TMPRSS2 in medium level expression in the endometrium. So he concluded that endometrial tissue is likely safe from SARS-CoV-2 cell entry. However, there seems to be an apparent increase in gene expression with increasing age, suggesting that the endometrium of older women may be at higher risk when they undergo ART. Also, they identified SARS-CoV-2 receptors in the embryos, and they harbor the necessary machineries for viral internalization and replication. So they go on to suggest that um, ART centers must avoid doing their procedures during the pandemic to avoid any hazard to the developing embryos. What about the human placenta and decidua? They also found ACE2 and TMP-RSS2 in these. They were highly expressed in the maternal fetal interface cells. And they were suggesting that because of this, this shows the risk for vertical transmission and placental dysfunction. Jing, therefore, because of these studies, that ACE2 is widely expressed in the ovaries, uterus, vagina, and placenta, concluded that SARS-CoV-2 may disturb the female reproductive functions by regulating ACE2. However, in a very recent study by Goad, he did not detect significant expressions of either ACE2 or TMPRSS2 in the myometrium, uterus, ovaries, fallopian tube, or breast, and found no co-expressed cell types for ACE2 in the female reproductive organs. These co-expressed cell types are important to work in the process of cell replication and cell entry and cell replication. And these are proteases, TMPRSS2, cathepsin B, cathepsin L, all known to facilitate the entry of SARS-CoV-2. So he found low concentrations of SARS-CoV-2 in the female reproductive tract in the human ovary. And he concluded that major reproductive organs involved in female fertility and pregnancy are not susceptible to direct SARS-CoV-2 infection, and the systemic effects of SARS-CoV-2 infection affecting vasculature and the risk of thrombosis may be more detrimental to fertility and pregnancy than the direct infection of the reproductive organs. Let's go back to the concept that both ACE2 and TMPRSS2 must be expressed, both of them expressed, to allow cell entry. So, what reproductive tissues have dual presence of ACE2 and TMPRSS2? In the study by Singh, he profiled single cell RNA of scarfs genes. The scarfs are a group of 28 genes that are found throughout cell entry, replication, and exocytosis of SARS-CoV-2 in the cell. So by profiling all these genes, then he would be able to identify really the probability that they can be active in cell replication of SARS-CoV-2. And this is what he found. He found a stark contrast between male and female reproductive organs, and that the early stages of spermatogenesis may be permissive for SARS-CoV-2 entry, but the oocytes and the ovary are unlikely to get infected. In a separate study by Zupin, he investigated in human female and male reproductive systems by inquiring online repositories. And he found that the male reproductive tissues could really be targeted by SARS-CoV-2, particularly the testis, which co-expresses ACE2 and TMPRSS, all both needed for viral entry. He said that the SARS-CoV-2, when it goes to the female, will probably not inhabit the female reproductive tract. But when it does the male, the testis will be a prime target, affecting various stages of spermatogenesis and potentially affecting fertilization. He concluded that the risk of SARS-CoV-2 infection in the human reproductive system is high among males and low among females, and potential infectivity of SARS-CoV-2 in reproductive tissues should be considered in reproductive medicine and management of in vitro fertilization in present and future generations. I'd like to conclude by summarizing that SARS-CoV-2 requires ACE2 receptors and TMPRSS2 to allow cell entry and replication, and that SARS-CoV-2 competes for the same receptors needed by ACE2 to mediate in the RASS system that protects various systems, and that sexual transmission of SARS-CoV-2 through vaginal fluids is unlikely but needs more research if truly present in the semen, and that non-coital sex transmission is possible as SARS-CoV-2 has been found in other body fluids. Finally, the risk of SARS-CoV-2 infection in the human reproductive system is high among males and low among females, and the systemic effects of COVID-19 causing thrombosis may be more detrimental to fertility and pregnancy than directly to the female reproductive organs. I'd like to close by honoring the frontliners during this long standing pandemic. Thank you for your attention.